So let me introduce our third speaker this morning. Dr. Meagher comes to us from Texas, and she's a professor of psychology and neuroscience. Welcome.
Hello. Thank you very much for the invitation to present our recent work. Doesn't look like my slides are up yet. I want to, before I get going into my presentation, is there anything that I need to do up here to get my slides going? I want to acknowledge my laboratory. I always run late, so I like to begin with acknowledging them. In particular, I want to acknowledge Susanna Creech and particularly Sophia Yu, who is the student who's done most of the work that I'll be presenting today. I'm going to begin with a brief overview of evidence for a link between adversity and pain sensitization, and then provide you with some recent studies from our laboratory that suggest that there may be an early adversity pain phenotype in humans, and that in the population that we study, young undergraduates, we find that early adversity is associated with the likelihood of having chronic pain as early as the age of 18. And then I'm going to end with a study that suggests that we can potentially reverse these stress-induced changes in pain sensitization using an exposure-based intervention. So as we heard earlier today, Gary McFarland's work has shown that really strong prospective epidemiological evidence for an association between early childhood adversity and increased occurrence of chronic pain, especially widespread chronic pain such as fibromyalgia. Animal studies also provide evidence that early life stress leads to the development of persistent widespread pain, and that this is further exacerbated by stress during adulthood. Work by John Levine's lab at UCSF has shown that this early maternal deprivation model that he uses has shown that it causes a persistent increase in interleukin-6 and is associated with an increase in muscle pain sensitivity. And that further, when you stress these animals during adulthood, you get a more profound sensitization of the pain, being unmasked. So there's sort of a latent sensitization that becomes apparent with stress during adulthood. And this seems to be mediated by the release of epinephrine and pro-inflammatory cytokines. And he's been really focusing on the role of these stress hormones in sensitizing peripheral afferents, and has evidence that it's leading to a phenotypic shift, leading to a hypersensitive pain phenotype. And these are persistent, widespread pain phenomena. A similar pattern has been observed by Beverly Greenwood using a visceral hypersensitivity model. Early life stress causing sensitization, but then it being further exacerbated by stress during later life. What we need is a human laboratory model to bridge these clinical epidemiological studies and these animal laboratory studies. So my laboratory has been looking at this issue by testing undergraduates at Texas A&M, and this slide depicts data from over 3,000 undergraduates who were pre-screened on the early trauma inventory self-report scale, David Bremner's measure. And we find that the average student is reporting about 5.7 adverse events. The median is 5 events. That sexual trauma is more prevalent among women, physical trauma more prevalent among men. Now, using this distribution, we can then identify the individuals who are 2 standard deviations above the mean, reporting 10 or more events as our high trauma group, and those who are below the median, below 5 events. And so we then take those 2 groups and contrast them in studies. So our first set of studies have looked at differences in pain sensitivity on the topical capsaicin test. We apply capsaicin to the skin, and during that 30-minute period, it starts causing a stinging, burning sensation at the site of application. And this is thought to reflect the peripheral sensitization that's occurring in the primary afferent nociceptors. You can ask the individual to report their spontaneous pain during that 30-minute application period. but it also is the key driver of central sensitization occurring in the spinal cord dorsal horn and in supraspinal regions of the brain. And with this increased C fiber sensitization, the input to the spinal cord is leading to this sensitization process called central sensitization. And you can infer the development of central sensitization using this test by testing mechanical sensitivity in the region surrounding the application site. And the phenomenon is referred to as secondary mechanical hyperalgesia. And we know from studies in animals that this is NMDA-dependent sensitization, and it's occurring in the spinal cord, but it's also mirrored by increases in the activity of central neurons and the expansion of their receptive fields at both the spinal level and at supraspinal levels. So we use von Frey filaments to identify the boundaries of the mechanical of the hyperalgesia by testing along each of these spokes, and then identify, we see a shift in pain sensitivity, and we use each of those points on each of the spokes to identify the area, to calculate the area of hyperalgesia. In addition to measuring secondary hyperalgesia as our proxy for central sensitization, we also measure flare. With the application of capsaicin, it causes vasodilation and increased blood flow to the skin, and we can quantify that by looking at blood flow to the skin. So we made a series of simple hypotheses in our first studies that high adversity participants would show increased spontaneous pain, increased secondary hyperalgesia, and increased flare. And this is our first study. This is a pilot study, and I didn't believe the data when I first got it, but I was excited to see this. It's a small study, includes just women, and what we see is the subjects in the high adversity group reporting more adverse life events are showing enhanced expansion of this area of secondary mechanical hyperalgesia, suggesting that they're showing an enhancement of central sensitization. And you could argue it's due to the input, the peripheral sensitization being amplified, but we're seeing it on that measure. And we've recently replicated this phenomenon in a larger sample that includes both men and women. And it's underpowered to really look at the effects of gender. If anything, the males are driving the means down a little bit. So we're hoping to add a few more men to the study to test that hypothesis. But we did see the effect being replicated. This effect seems to be mediated by PTSD symptoms, so it's accounting for most of the variance in secondary hyperalgesia. At the same time that we're seeing sensitization on this dynamic measure of pain that perturbs the pain pathway to reveal this underlying sensitivity, we're seeing no difference on mechanical pain thresholds when we test at a region that's remote from the capsaicin application. So these are often referred to as static measures of pain, just simple threshold measures, because they do not in themselves perturb the pain pathway. We did not see a significant effect of childhood adversity on spontaneous pain. There's a slight hint of something there, but it hasn't come out. And we also looked at capsaicin-induced neurogenic flare using laser Doppler imaging. And you can calculate an area measurement of the flare. And panel A shows you a typical at low adversity flare response, and the panel B is showing you a high adversity. We have, at this point, a marginally significant effect. It's 0.7. So we hope with continued additional subjects, we'll see this pull out in one direction or the other. Now, the next study looked at an independent measure of that's thought to reflect central sensitization. It's referred to as temporal summation of second pain or wind-up, which has been studied extensively in animals. And this measure is thought to reflect homosynaptic sensitization occurring in the spinal cord dorsal horn. What's happening is you're getting fixed presentations of heat pulses, so they're fixed intensity, but there's an experience of perception of the pulses increasing in intensity with the repeated presentations of the pulses. And so you can plot the slope of the pain intensity ratings over the 10 heat pulses and and use that as your measure of sensitization. Studies that have been done in chronic pain patients, such as fibromyalgia patients with chronic widespread pain, they tend to show an enhancement in central sensitization of pain and reflected by enhanced wind-up and steeper slopes. They also show enhanced after sensations, which is sort of a persistent, lingering sensation after the last train of pulses. So this is the data of the average scores. This is before we convert them into slopes. We see that the high adversity group is showing enhanced temporal summation and a slight increase in after sensations. If we look at the slope analysis, the high adversity group is showing a steeper slope compared to the low adversity group, which is almost at 0. We also looked at whether or not the slope was predicted by dissociative symptoms at the time of the adverse events. And there are 2 items on the scale that we're using that measure the reaction to the event at the time of the event. And in addition to dissociation, there's a measure for emotional disturbance at the time, the degree of fear and terror and helplessness in response to the event. We found dissociation, high adversity subjects with dissociation reports showed the steeper slopes. We didn't see anything for reports of emotional disturbance, though, at the time of the event. Similar to what we saw with the capsaicin test, when we look at static measures of pain, we're seeing normal static measures. So subjects are normal in terms of pain threshold, and they show equal temperatures to induce a moderate pain rating on a numeric rating scale. So again, it seems that the dynamic measures that perturb the pain pathway and unmask this underlying sensitization are revealing these effects. But when you use static measures, we're not seeing much. We also looked at whether or not the emotional reaction to the pain testing itself could explain the differences we were seeing in pain sensitization. We didn't see any differences in the immediate emotional reaction to the temporal summation testing. There are no differences between the high adversity and low adversity group. What we did see, however, was that the high adversity group showed a blunted sympathetic and cardiac response pattern throughout testing. They were blunted at the beginning, at baseline, and throughout pain testing. And this pattern has been seen in acoustic startle studies of individuals who report childhood adversity. We've also looked at individuals who were pre-screened for high and low levels of borderline personality disorder features using the personality assessment scale, borderline scale. That scale is composed of 4 subscales that measure affective dysregulation, negative relationships, identity disturbance, and self-injury. Because of the nature of this population being a non-clinical sample, we didn't see much evidence of self-injury. What we were interested in was seeing whether or not the different subscales of this measure would predict who developed temporal summation of second pain. As you can see, there was a robust increase in temporal summation of second pain in the high PAI-BOR scale subjects, indicating that they are more sensitive, and they showed steeper slopes. And when we looked at which subscale was explaining the variance, we had assumed it was going to be the affect dysregulation scale, and it wasn't. It was the negative relationship scale. And this is consistent with the idea that this long history of interpersonal conflict and stress in relationships may be driving this phenotype that we're seeing in the early adversity conditions as well. Okay, so together the data I've been showing you suggests that there may be a adversity pain phenotype characterized by enhanced central sensitization. Central sensitization is believed to contribute to the development and maintenance of chronic pain. So we wanted to ask in this population of undergraduates whether or not adversity was related to an increased likelihood of developing chronic pain or having chronic pain. So we took the 3,000 subjects that we pre-screened and we looked at, using a hierarchical regression analysis, whether it determined whether people got chronic pain or not, and what the determinants were. And we found that the number of early adverse life events increases the likelihood of chronic pain. The cumulative effects of having multiple adverse life events predicted having any chronic pain, chronic back pain, or dysmenorrhea in these 18-year-olds. And we were controlling for depression and health behaviors and so forth, so it's unlikely to be explained by current emotional distress. We also found that history of self-reports of early serious personal injury or illness increased the likelihood of any chronic pain condition, chronic back pain, dysmenorrhea, and chronic headache. Now, obviously, this study is very coarse, but we wanted to see, at least in this population, whether we're seeing something like what is being reported by Gary McFarland's group with these lovely prospective studies that we're not able to conduct. This last study that I'll talk to you about is looking at whether or not we can reverse this phenotype. And we're looking here at the effects of an exposure intervention. And the rationale was that most psychological interventions for trauma history tend to use some form of exposure-based therapy, where you're repeatedly revisiting the memories and cues associated with the early trauma with the hope of reducing anxiety symptoms. In the laboratory, we came up with a procedure. We borrowed from Jamie Pennebaker his written emotional disclosure of trauma procedure. And he had previously, and others have previously shown, that written emotional disclosure of trauma leads to a short-term increase in emotional distress and arousal. But in the long term, you see improved physical and mental health outcomes. You also see improved immunological functioning. And there have been studies done in chronic pain patients suggesting that it leads to improved outcomes in fibromyalgia patients. So our hypothesis was that we would see a short-term increase in capsaicin-induced pain, but that at 1 month, at a long-term follow-up time point, that we would see a reversal if this procedure works through that kind of a mechanism. So we pre-screened for high and low trauma history, and we assigned half of the subjects in each condition to a written disclosure condition where they were asked to write about their most traumatic life experience, or they were assigned to a control condition where they were asked to write about time management, rather boring neutral condition. And we did pre-post measures on their emotional state and level of depression and trauma symptoms and so forth, and they were significantly different in terms of their trauma scores at baseline if they were in the high trauma versus low trauma group. Now, so we did this as a between-group design where we tested half of the subjects 1 day after writing about the traumatic or neutral experience, or we brought them back 1 month later. Okay, so that's the design. And what we found was data that are generally consistent with our hypothesis. In the trauma history group, disclosure produced a short-term increase in secondary hyperalgesia when pain was tested 1 day after writing. You can see that's day 4, that the disclosure trauma history group is showing enhanced areas of secondary hyperalgesia and increased intensity ratings to the mechanical stimulation as well. But the subjects that were tested 1 month later were seeing that relationship reversed. And this finding is consistent with previous clinical studies reporting long-term symptom reduction in fibromyalgia patients largely. That's been the most reliable group for which this has been observed. But previous work hasn't had a mechanism, and this work is suggesting it may be that you're reducing the central sensitization process. Now, how that's happening is unclear. It may be through altering the release of epinephrine. It may be down-regulating interleukin-6 if John Levine's data are correct. There are a host of possibilities. We did not see an effect on spontaneous pain, no effect of these manipulations. So that's why we're thinking it's specific to central sensitization. Interestingly, we looked at the emotional responses to the writing process. Both the trauma history and no trauma history group in the disclosure conditions reported negative affect as they were writing. So this was distressing, but it was no more distressing in the trauma history group. They were not different. When we looked at their emotional responses to the pain test the day following the trauma, both groups in the disclosure condition experienced greater negative affect during pain testing, but it didn't differentiate between the low or high trauma group. The variable that seemed to predict change was in the text analyses. We did Pennebaker's text analysis, and we found that there was greater use of positive, causal, and insight words over the course of writing, and that the increase in the use of positive words in the writing of the trauma experience on day 3 was related to the reduction in area observed 1 month later. So it predicted the improvement. Okay, so I've provided evidence, at least some preliminary evidence, that there may be a pain adversity phenotype related to childhood adversity that's characterized by central sensitization. That this, in the same population that we're seeing this phenotype, that childhood adversity appears to be related to an increase in vulnerability or the likelihood of developing chronic pain, and a hint that there might be some possibility of reversing this through exposure-based therapy. And I just want to note that in addition to our work, Salomon's just in the past few years has shown that a cognitive behavioral intervention can also reduce the area of secondary hyperalgesia. So it's not just this study, but another study that's using a psychological intervention showing a reduction in area. That's it. Questions?